Hi, everybody. Welcome to this latest program of how NQF members are responding to the challenges around COVID-19. My name is Sheila Franklin, and I am the Director of Government Affairs at the National Quality Forum, and I will be your host today. We are glad you could join us for this program on how the North Carolina Department of Health and Human Services rapidly responded to the COVID-19 pandemic by making hundreds of eligibility, benefit, payment, and technology changes to enhance coverage for Medicaid beneficiaries and to help ensure financial stability for Medicaid providers. This program is made possible by you, the members of the National Quality Forum. Members are the driving force behind NQF's mission to advance measurable health improvements. Together, we do the work that enhances healthcare value, makes patient care safer, and results in better outcomes. Members continually demonstrate their shared commitment to the NQF mission through engagement and service, and our presenters today are no exception. Amanda Van Fleet is the Associate Director of Innovation at the North Carolina Medicaid in the North Carolina Department of Health and Human Services. She leads various innovation initiatives in NC Medicaid, including the Health Opportunities, Social Drivers of Health pilots, the transition from fee-for-service to value-based payment, and a Medicaid Accountable Care Organization program. Amanda has over 10 years of experience focused on value-based payment and improved care delivery for low-income and high-needs populations, and has held roles at CMS's Center for Medicare and Medicaid Innovation, the Kaiser Family Foundation, the Center for Healthcare Strategies, and the U.S. House of Representatives. She holds a Master's in Public Health in Health Policy and Management from Columbia University's Mailman School of Public Health and a Bachelor of Business Administration from Emory University's Gozeta Business School. Amanda is also one of NQF's inaugural Quality Policy Fellows. Emma Sando is the Associate Director of Strategy and Planning at North Carolina Medicaid. Emma focuses on federal health authorities, long-term services and supports, eligibility, and strategic projects and initiatives. She has worked on operations related to the North Carolina healthcare transformation and shift to managed care. She worked at the Centers for Medicare and Medicaid Services and the Department of Health and Human Services. Before joining federal service, she worked at the Center for American Progress and the House Ways and Means Health Subcommittee. She received her undergraduate degree at UC San Diego, a Master's in Public Health from the George Washington University, and a PhD in Health Policy from Harvard University. Just a few logistics as we get started. We hope you'll take an active role in the question and answer portion of the program. However, please help us stay on topic and refrain from questions or comments that aren't related to the information being shared today. We have muted all phone lines to ensure that unexpected noise does not interfere with the program. We will be taking questions through the web interface and through the phone lines. If you are on the web, we are displaying instructions there for how you can ask a question. If you are only on the phone and unable to see the instructions, I will prompt the audience when it is time for phone questions. At that time, you can hit *7 on your phone to unmute your line. When you have asked your question, please mute your line again by hitting *6. With that, I would like to turn it over to Amanda Van Fleet to kick off the program. Amanda, you can hit *7 on your phone to unmute.
Great. Can you hear me okay, Sheila?
Pardon me?
Oh, just checking to make sure you could hear me.
Yep. All good.
Wonderful. Thank you so much for having us. Emma and I are both excited to be here today and share about our experiences in North Carolina. So obviously, COVID-19 has impacted all of us across the globe, and we've been figuring out how to deal with it in real time as it's rapidly changing. So Emma and I are here today to provide a state's perspective to addressing the pandemic and how we've been responding to COVID not only as a department of both Health and Human Services, but specifically as a Medicaid agency. And as a Medicaid agency, our highest priority is protecting our beneficiaries and also our providers to make sure that our providers have the resources that they need to address the pandemic, that our beneficiaries have access to testing and health care, as well as social services in order to keep the individuals in our state healthy. So we in North Carolina are trying to innovate and implement changes quickly since the pandemic, and not only the pandemic, but the recommended responses and the evidence are all changing so quickly. And just speaking for myself personally, I have been impressed with how quickly we've been able to respond and make so many changes in such a short period of time. I really hope that our ability to do that will continue after the pandemic, since it's been shown that we have the capabilities to do that. So for today, we will start by providing a general overview of the processes that a state can take to respond to COVID-19, in addition to the various federal authorities that are available for a state to request flexibilities to respond to a pandemic. And then we'll dive into some more specifics about the policy changes we've made and actions we've taken in North Carolina, specifically related to eligibility and enrollment, benefit changes, provider payment changes. And through our COVID response, we know that historically marginalized populations such as African Americans, Latinx and Hispanic, and American Indian, Native American populations are disproportionately affected by COVID. So we'll give some information on how we're specifically focusing on historically marginalized populations and health equity. And then we're also doing some work in Medicaid and across the department to address social needs that may be compounded or affected by COVID-19 and how we're using technology to help us do that. And then finally, we will try to leave some time at the end for questions and answers. So with that, I will pass it over to Emma to start us off.
Hi there. Hopefully I unmuted myself okay. So we're going to first discuss the process of state responses. State governments, particularly Medicaid programs, by their very nature, have many stakeholders that they must respond to. They must coordinate across the state with our federal partners, with our financial needs and strained budgets, and operational impacts as well and constraints. So that's not in any particular order of what the process looks like. Oftentimes state Medicaid programs are doing all of this at the same time, if not doing multiple things at the same time for each one of these. So going into a little bit more detail, across the state, we work with our partners within DHES, so with our public health partners, people working on mental health, as well as other parts of the agency to coordinate our strategy and our focuses. We have a variety of cross-department work streams that have focused on a variety of different initiatives, including telehealth, historically marginalized populations, and some of the other work that we are focusing on. North Carolina, like a lot of other states, has a Medicaid program that has a lot of work done by the county offices. So for our program, the eligibility and enrollment processes are largely done by county DSS offices, Department of Social Security offices. And for all the changes that need to be made, we need to work with these offices to train individuals on the ground that speak with beneficiaries on a regular basis to let them know the changes so that those are getting to the beneficiaries and people are able to understand it. As well, any state can tell you that the governor and the legislature give direction to what the state's priorities are and the constraints that the state has to work with. Since Medicaid is both federal and state, we need a lot of authority from our federal partners through a lot of different means. I'll go into a little bit more of the detail on each of these on the next slide, but to give a broad overview, 1135 waivers have been discussed as the main way that disaster waivers are implemented. However, these are only a small portion and often deal with the non-financial aspects of the Medicaid program. So things like prior authorization or other flexibilities for timelines and other programmatic changes. We also have submitted an 1115 waiver, which is a bit more broad and specific to the disaster to make changes beyond what is allowed under current disaster law. Our state plan amendment, our SPA, can be amended for a specific period of time through what is known as a disaster SPA. But our waiver programs are amended through a separate process called the Appendix K. In addition, we have a number of authorities that we implement and are allowed to implement quickly during an emergency. And North Carolina has a history with hurricanes, so we have a certain set of authorities that we implement when there is a state of emergency, and those are approved through a concurrence letter process. Additionally, with the economic downturn, the budget outlook has been strained in every state. So while the Medicaid program is asked to do more, we have less funds to do that part of the countercyclical nature of the Medicaid program. As such, changes to the Medicaid program that change how we are working often require legislative approval, and the variety of different congressional bills have given indication of what we can and cannot do. So a lot of federal funding that is available is tied to maintaining our effort on eligibility levels and current operations. Operational impacts are very difficult in this work from home time, as we are simultaneously trying to get everyone, all state employees, to work from home, but we need to make very large structural changes to our Medicaid program. We need to change eligibility and payment systems, clinical policies and guidance very rapidly, and county eligibility workers who primarily served people on a face-to-face basis are working from home in a lot of places to reduce that contact. So changing all of those operational systems is especially hard right now, and an impact that we are always concerned with. Next slide. So to go into a little bit more detail about what North Carolina has submitted, we submitted a North Carolina-specific 1135 waiver back in mid-March. One of the first things we did to change a lot of the processes that are not related to financial changes to the program. We received partial approval on March 23rd, and since then CMS has issued a number of different blanket waivers, and we are exploring other ways that we can make improvements to the program and deadlines and whatnot that we can amend. And we'll go into a little bit more detail about some of those things that have changed. The concurrence letter that I mentioned before was also submitted in mid-March, and we changed a number of our eligibility systems to allow some flexibility to bring more people into the program and maintain eligibility for people that are in emergency situations. We submitted a disaster SPA specific to the CHIP program because we have Medicaid and CHIP are programs that we run and need to submit separate state plan amendments when we are changing those programs to meet the needs of the beneficiaries. We are still awaiting approval of our 1115 waiver, which will make some changes to how people enroll in long-term care, what's required of them, long-term care programs, as well as we've requested to provide additional funding to providers that have received reduced amounts of payments due to stay-at-home orders. We have 4 different waiver programs in North Carolina for specific populations, and these different waiver programs primarily for long-term care and behavioral health program, or the 1915C, we've received some flexibilities specific to those programs and our managed care organizations that run those. The disaster SPA we've been submitting in rounds, so this has a lot of benefit changes and other policy changes within it, and is a very large document that makes a variety of different changes to the Medicaid program. There's also a number of flexibilities that don't require federal approval that we'll go into detail in a little bit, but prescription drug changes for the most part and some telehealth changes do not require federal approval. Next slide. So how we've improved the Medicaid program. Next slide. North Carolina, like many states, and getting back to this point about the legislature, requires legislative approval before making eligibility changes, and the Families First Coronavirus Response Act, which was passed, it was the second coronavirus bill from the federal government, included a optional Medicaid eligibility group that would allow for testing of uninsured individuals. And we recently received approval from our legislature to explore going into or taking up that option. So we are evaluating that, but that would provide additional testing services to uninsured individuals. We are looking to we have also gone beyond that for our currently enrolled beneficiaries and currently eligible beneficiaries by allowing self-attestation for all eligibility criteria except for citizenship status to when a person is unable to furnish certain verification of eligibility. If you can't get to a DMV because of stay-at-home orders, for instance, and you're applying for Medicaid online, you don't necessarily need that verification that the DMV would perhaps provide. We are, as part of the Families First Coronavirus Response Act, in order to get an enhanced FMAP increase, we are also required to keep people that are currently in the program on the program. So we are automatically renewing coverage for those people who have a yearly redetermination during the public health emergency. And that's one area that you may have seen a number of reports about how Medicaid enrollment is increasing dramatically in states, and it's important to remember that that's partially due to the automatic renewing of coverage. We have also waived a number of enrollment fees and are maintaining eligibility for people who may be having to stay at home away from the state of North Carolina. I'm going to turn it back over to Amanda to go over some of our benefit changes on the next slide.
Great, thanks. Excuse me. So we have made over 100 benefit changes, including creating multiple new codes to allow providers to be paid for providing these adapted or changed benefits. the benefit changes can be created through a couple of different ways. Some of those states have the authority to make ourselves without federal approval by making what we refer to as clinical policy changes, and some do require federal approval to make changes to, and for those we need to go through our disaster spa that Emma mentioned. So this is a sample of some of the benefit changes that we've made, and I'll just highlight some. Many of our benefit changes have been to allow services to be provided through telehealth, which Emma will go into more detail about later. But we've also done a lot of outreach to beneficiaries and providers about these telehealth changes and created codes for those services as well. So in addition to that, we have made some benefit changes that attempt to prevent unnecessary hospitalization, since we know that our hospitals are struggling with capacity, and to try to keep hospital beds reserved for the most serious COVID cases. So one change that we made is to allow ambulance providers and suppliers to treat beneficiaries in place without transporting them to a hospital. Usually an ambulance provider will obviously have to transport an individual to a hospital in order to get reimbursement, and we're trying to prevent that. We're also making some policy changes to encourage proper social distancing, isolating, and quarantining, such as covering pharmacy drugs to be mailed to people's homes rather than requiring them to pick them up from a pharmacy. And we're also allowing certain services to be provided in the home, such as certain infusion therapies. We've also made changes to ease administrative burdens to allow providers and the state to focus on pandemic response, such as easing restrictions on reassessing and reauthorizing certain services annually, or trying to reimburse NEMT providers that wait during a patient's doctor appointment. So trying to ease some restrictions that will make it easier to get people care. We're also trying to expand the healthcare workforce by allowing certain services to be done by a physician assistant or nurse practitioner without supervision by an attending physician. And we are waiving many things like prior authorization, training requirements, service and supervision requirements for 25 different behavioral health, IDD, and substance use disorder services. And then we've also waived our cost sharing for testing and treatment related to COVID-19 and suspended any enrollment fees and monthly premiums that we have to make sure that Medicaid, that cost is not a barrier to COVID testing and treatment for our beneficiaries. And then on the next slide, Emma will take it back to talk about more specifically about some of our benefit changes.
So for our telehealth changes, has been very exciting in the state of North Carolina. We didn't have a lot of flexibility for telehealth prior to COVID, and had just begun the process of reevaluating our telehealth policies when March started. Well, the reevaluation began well before March, but it was pretty nascent in the beginning of March, and went into hyperdrive in response to COVID. So we've made quite a number of changes, and we're able to learn from a lot of other states about the processes that they've done, and make a number of changes to bring a lot of flexibility in telehealth. We've changed the originating site. That's where a patient lives or the patient is being seen. So we allowed additional flexibility there. The distance site, which we only previously allowed consultative distance sites, now could be medical providers where the medical provider is. We removed prior authorizations for telehealth services. We started with expanding flexibilities to our primary care providers and behavioral health services, as those are some of the key providers for Medicaid beneficiaries. And then we expanded that significantly to include a number of other providers and expanded beyond the primary care to include dental, pharmacists, other specializations. And then we allowed a large number of different utilization of video cell technology, and it reinforced the idea to providers that they would receive parity for services that are provided with that video component. They don't receive the same payment rate for phone calls as the video component really adds a different element for different services that are allowed to be covered through telehealth. We looked at and expanded our flexibilities in HIPAA compliant technology in emergency circumstances, and had a particular focus and continue to have a particular focus in getting our FQHCs and rural health centers up to speed on telehealth and increase utilization amongst these very vital Medicaid providers. The things move so rapidly that I failed to update this particular parentheses that CMS now does pay for FQHCs and rural health centers as distance sites. They had previously not been covered, but that changed through the CARES Act. So FQHCs and rural health centers are particularly important, and we've done a number of outreach efforts to get them more engaged in telehealth, partly because North Carolina has a very large rural population that largely relies on these sort of centers. Next slide. As I'm sure you're all aware, this pandemic has hit especially hard for people that require long-term services and supports, of which Medicaid is a primary payer. So we've had a special focus on our various nursing facility centers, as well as all those individuals that require long-term services and supports. We've made some flexibilities to allow people to stay in our waiver programs. So they previously had to meet minimum utilization requirements, and now we've waived those so that people can continue to receive services if they are temporarily interrupted due to stay-at-home orders or other restrictions. We've waived a variety of different services or ways that people can get home and community-based services and skilled nursing facility services more easily. I'm not going to read that whole list to you, but essentially we've removed a number of face-to-face requirements, knowing that people can't be face-to-face, and that would present a hazard. We've allowed for additional telephonic and telemedicine particularly for home and community-based services that weren't previously allowed. And we've reduced a number of different administrative barriers to receiving services, such as prior authorization. North Carolina also had a number of restrictions on family members, live-in relatives, and legal guardians providing home and community-based services. So we've lifted those restrictions to be able to make it so that it's not always a stranger coming into an individual's home and risking that individual spreading the virus if it's in the home or outside of if it leaves the house. So having people that are already living with the beneficiary provide services is a big change to reduce spread, but also often a change that beneficiaries really like and something that is very popular. We've increased coverage for allowing certain services to be provided in alternative settings, sort of trying to make it so that the hospitals, particularly hospitals that are experiencing high COVID demands, to be the last resort and allow for care in settings that would not normally be allowed for care, and being able to respond when there is a emergency in a nursing facility. We are paying for additional PPE and training for our facility employees, and enhancing other training on how to reduce the spread of infection. We are extending certain timelines on screenings and other requirements that often are not as essential to the to COVID, to allow the facilities to really focus on the COVID emergency. We've extended a lot of payment incentives, and next slide. There we go. All right. So the first being that we've enhanced retainer payments that support the sustainability of home and community-based service providers, allowing people to continue to receive services and really make sure that the providers that are really hard hit in the home and community-based settings are receiving payments while they may not be able to provide care to individuals. We also implemented a 5% rate increase to certain parts or certain services that provide long-term care. The legislature went ahead and increased that by an additional 10%, so it's a total of 15% rate increase to certain long-term care providers. North Carolina is one of the few remaining states at this time with a fee-for-service program, so these changes were made through fee-for-service rate increases, and that's specifically how that was accomplished. And in addition, we are providing additional hazard dollars to providers that are seeing outbreaks in order to address those outbreaks quickly and remedy those situations. But as part of that 10% increase that I mentioned before, the legislature also increased the rates for all of the other providers by a 5% increase. So the providers that weren't included in that 15% rate increase saw a 5% rate increase as well. So this is in part due to the lower rates of utilization that we saw in March, April, and May, and the beginning of June, as people weren't utilizing services that they may have already seen. And that was to try to make it so that Medicaid beneficiaries will still have access to those services when they are able to comfortably leave the house and go see providers for elective procedures. And then we also allowed additional Medicaid providers to request an interim payment methodology to allow for additional flexibility in how providers are paid. All right, I'm going to turn it back over to Amanda so I can get a sip of water, and she's going to take it from here.
Thanks, Emma. Excuse me. So as I said earlier, we know that historically marginalized populations like racial and ethnic minorities are disproportionately affected by COVID-19. So we realize that to truly achieve health equity, that means we need to invest in and direct a disproportionate amount of resources to those populations. So we're really looking at historically marginalized populations in our COVID response as our priority population. So to really focus on them first and what they need in order to have the resources that they need to get access to testing and treatment and social services that they need throughout the pandemic. So to try to focus on this, we've developed a department-wide work group to focus on historically marginalized populations. And this work group integrates with and works with all of our other COVID-19 work groups at the department. So we have those on testing, on contact tracing, on communications, on data, to ensure that all of our COVID responses are operating through a health equity lens and to align to some common objectives. So those objectives, first we want to effectively reach historically marginalized populations, which our biggest focus at first is on African American and Black populations, Hispanic and Latinx populations, Native American and American Indian populations, refugee and immigrant populations, both documented and undocumented. So first we want to effectively reach those populations and provide education and guidance on COVID-19 since those populations are disproportionately impacted. We want to be sure to connect these populations to medical and behavioral health care providers regardless of their ability to pay, and we're trying specifically to ensure that they are connected to a medical home through the testing and treatment process. We're aiming to link historically marginalized populations to needed resources to address social drivers of health. And we're also aiming to protect essential frontline and undocumented workers from both intimidation and exposure to COVID-19 and honor worker rights. And we are aiming to ensure that all COVID-19 related procurement and contracting activities include an equitable lens. So we're really trying to contract with minority and women-owned businesses. So for each of these objectives, we have a sub-work group that focuses on those objectives. And each subgroup has concrete actions or tactics that they're taking to try to achieve those objectives. So for example, some of the things that we're doing are creating patient-facing, culturally competent content in multiple languages, in the most common languages spoken in North Carolina, ensuring that there are testing sites in underserved communities and connecting especially medically disconnected individuals to a medical home, recognizing that there is testing bias and creating resources to educate healthcare providers to minimize unintentional bias, and connecting historically marginalized populations to social services such as non-congregate housing, food, transportation, domestic violence, and employment resources. So this is an effort that we are admittedly constantly trying to improve. So we'd really welcome any recommendations, thoughts, and insights onto this, either during the Q&A, through email, et cetera. But we're constantly trying to improve the process. Next slide. So social drivers of health are a big priority to the department, and I think that if anything has shown us that social drivers of health are important, it's COVID. Responding to this pandemic has not only been a Division of Public Health response, or specifically an infectious disease or epidemiological response. It's really been an all-hands-on-deck response throughout the department and also outside of the department. For example, in our Department of Commerce, which deals with unemployment, our Department of Public Safety, which organizes emergency response. So it's really been a statewide effort in addressing all the impacts of this pandemic. So we know that the pandemic has been causing people to lose their jobs and need economic assistance. People who are diagnosed or exposed to COVID and need to isolate quarantine separately from their family may find themselves in need of a place to stay and suddenly housing insecure. Children who rely on getting food from their school may now be food insecure because schools are closed. So there's a range of social needs that are not being addressed and met during this time. So we've been prioritizing both accessing and using funds appropriately to ensure that social needs are addressed due to COVID, as well as healthcare needs. So this slide and the next slide are a snapshot of our efforts, but I think that they're pretty representative. So I'll go through a few initiatives that we're doing related to food and nutrition. We applied for and were awarded funding from the USDA for a new pandemic ABT program that they're running, which adds $250 per eligible child to the family's EBT card to spend on food, on eligible food. So we estimate that this will get food to about 800,000 children who are eligible for free and reduced lunch at school, but their schools are currently closed due to COVID. And the USDA reapproves that funding a month at a time. So the funding is ongoing for that throughout the pandemic or the emergency period. USDA is also nationally maximizing the amount of SNAP benefits for eligible families. But North Carolina is also participating in a pilot program with the USDA that allows SNAP-eligible families to purchase groceries online for delivery to allow for social distancing and isolating rather than having to physically go to a grocery store. We also received a little over $22 million in Administration for Community Living grants to provide home-delivered meals and emergency response services such as PPE or food supplies to older adults. So a lot of nutrition programs. We also have a lot of housing support and supportive programs related to housing. We received approval and financial support from FEMA to stand up a non-congregate sheltering site for individuals that are isolating or quarantine or even high-risk populations to prevent exposure by socially distancing. So through that program, we received a 75% match from FEMA to develop up to 16,500 sheltering units, which can be individual sheltering units in hotels or dorms or trailers, any of those types of organizations that we can get to participate. And those funds also cover some support services like laundry, food, cleaning, and security. And then we also received both funds from HUD and the Coronavirus Relief Fund to do a rapid rehousing program for people who have lost income or employment due to COVID and provide case management for housing and employment services. Next slide. Thanks. And then the last housing initiative I'll mention is another HUD grant for homeless assistance and prevention activities, recognizing that homelessness will increase because of the pandemic. We're also focusing on childcare. So we have ACS funding for multiple childcare programs, especially to support individuals who are frontline or essential workers during the pandemic. And then we also have gotten some coronavirus relief funds to provide transportation services for elderly and disabled individuals to get to testing sites or grocery stores or places that they may need and lack transportation to access. And then finally, we're requesting coronavirus relief dollars now to provide social services to children and families that are impacted by domestic violence or other factors during this time to try to prevent children from entering the foster care system. So a variety of social support initiatives going on throughout the department. Next slide. Sorry, I had to get a sip of water. So in an effort to try to support these social services and to try to connect individuals to the right social services that they need, we're using technology to develop an infrastructure for that. So our state has been implementing a technology platform that we're calling NC Care 360, which is a Unite Us platform. It's a public-private partnership between the department and the Foundation for Health Leadership and Innovation. And then we also have a few other partners that we're working with, like our 211 line, United Way, and Expound. So this will be the first statewide coordinated network that links the healthcare and human service organizations through one shared technology platform that allows for both a statewide resource repository of community-based organizations and social service agencies throughout the department, but also an electronic referral platform that allows healthcare providers, insurers, human service providers to connect people to resources by making an electronic referral, and then being able to close the loop on that referral, so following up to see if, in fact, the individual did receive the services that they're in need for. So we were on track to expand NC Care 360 by the end of this year, so by January 2021. It had been launched in about half of our counties a couple months ago, probably at the beginning of COVID, and we ramped up our onboarding of organizations onto the platform so that it's now currently statewide in all 100 counties. So not every community-based organization is on the platform yet, but it's available with some community-based organizations in every county, and we're still trying to rapidly onboard CBOs onto the network. And let's see, I think that is it. So I think we're happy to take questions now if anyone would like to ask them.
Okay, great. Thank you, Amanda and Emma. We do have a question already in the chat, and if anyone else would like to ask a question, you can type it in the chat box, or we'll take phone questions momentarily. While you guys were giving your presentation, Craig Jeffries had posed a question in the chat, and I see that you're on the line. Craig, would you like to ask your question in person? If so, you can hit *7 on your phone to unmute your line. I was surprised people want to do that. Okay, I'll ask a question for Craig. He was asking, is the North Carolina system to address non-medical drivers of health, food, housing, transportation, et cetera, is that included, or does it overlap with your comments on the COVID response in North Carolina?
Yeah, so we have, across the department, we have a general interest and focus on addressing social drivers of health. I think probably what the question is referring to is our pilot program, our Healthy Opportunities pilot, which we received authority through our 1115 Medicaid transformation waiver. So because our Medicaid transformation is currently on hold because we don't have a state budget, the specific development of the pilots is currently suspended until we have a budget that allows us to launch managed care and therefore launch the pilots. But I think as I got to in my presentation, we're still definitely committed to addressing social drivers of health. So we're just doing so through different mechanisms through COVID right now.
Okay, we'll go to the phones, and if there's anyone on the phone that has a question to pose, you can hit *7 to unmute your line and ask your question, and we'll give a couple of minutes or A little bit of silence here to give people a chance to come off mute and ask their question. Okay, looks like we have a question from John Shaw, and John asks, I'm one of many NQF members interested in alignment of medical and social services and associated measures. Have you defined any specific process and outcome measures for SDOH referrals in your efforts? For example, days from referral to CBO action, community-based organization action. Days from referral to closure of the referral, patient-reported satisfaction on both the process and the service needs, those kinds of things.
Yeah, that's a great question. So yes, we are thinking about it. We are still trying to be able to capture them. So for our pilot, the only measure we have the ability to collect right now is from our health plans is the number of SDOH screenings that have been made. Through NC Care 360, we can get additional data. You mentioned some of them. For example, we'll be tracking days from when a need was identified to when a referral was made, number of days between when the referral was made and when the individual got services. And I believe that we will be capturing demographic information about individuals, so we'll be able to capture some data on race and ethnicity. So we'll get some data through NC Care 360, but it's certainly something that I'm trying to think through as far as what are the right ways that we can measure social drivers of health. And I mean, through our pilots, we'll be able to look directly at the impact of using Medicaid dollars to pay for social services and how that impacts both health outcomes and quality and healthcare costs. But in the meantime, we're trying to figure out kind of what the right ways are and what our abilities are to be able to measure that. So it's something I'm interested in exploring also, if anyone has recommendations on good measures to use.
Okay, and our next question is from Rainer Emily. Are any of the new initiatives here to stay beyond COVID-19, such as better acceptance of telehealth?
I can take that one, Amanda. Yeah. So the answer is it is yes to some and no to others. So there are a number of authorities that will go away with the public health emergencies. For example, anything that was made flexible by 1135 waivers are after the public health emergency ends, will essentially be turned off. And some of that is federal law that doesn't allow the state to maintain some of those flexibilities. But some of the flexibilities, the state is currently in the process of reviewing and looking into what has worked and what needs changes, or how we would go about implementing this during a non-pandemic situation. You mentioned telehealth, and that is particularly an area that we are looking at as maintaining and encouraging where appropriate, but potentially making some changes and adjusting our telehealth policies where we're seeing that it doesn't work as well. This has given us an opportunity to really evaluate using evidence of how these policies should be implemented.
All right, and then Eileen Chappelle has a follow-up question. How do you determine the most critical social drivers of health from your state's population?
Yeah, that's a really good question. We worked with our State Center on Health Statistics to develop a social needs hotspot map where we were able to map. I believe we have about 20 social indicators around housing, transportation, food security. We were able to map need at the census tract level to kind of map out where certain needs were highest throughout the state. So right now we are overlaying that data with COVID data to see how they interact in order to try to figure out what initiatives will be most impactful in different areas of the state. So that's one way. And then I'll just say for our pilots, we focused on 4 priority areas, which are food, housing, transportation, and interpersonal violence. And we landed on those 4 partly through negotiations with CMS, but also because those are 4 indicators that have some of the highest evidence base now that investing in them impacts health and healthcare costs. So trying to take an evidence-based and data approach where we can.
Okay, and then we also have a follow-up question from John Shaw, and he wanted to know if you could share your list of social driver indicators.
Sure. I don't have them off the top of my head, but I am happy to get that list out. I can provide it to NQF, and maybe they can provide it to the folks on the call today.
We would be happy to do that. And that concludes all of our questions. Sheila, do you want to wrap up?
Great. Thank you so much. In closing, I'd really like to thank Amanda and Emma once again for making the time in their busy schedules to share with the NQF community their experiences in responding to COVID-19. And I'd also like to thank all of you for joining us today. We hope that the information that was shared today will be informative as you face these challenges continually in your organizations. We know that many of you are on the front lines of the response, and we are so grateful for your leadership and your action. Please be on the lookout for a brief survey about today's program. If you could take 60 seconds to give us your feedback, we would really appreciate it. I encourage everyone to tap into our amazing community of healthcare quality leaders as we navigate these challenges together. We have an active conversation underway on our online community, Member Connect, and the recording of this program will be posted there shortly. This concludes our program. On behalf of everyone at NQF, we wish you continued good health amidst this pandemic. Thank you.